Good morning, everyone. We appreciate your interest in coming to our course this morning, Management of Common Problems or Practical Solutions in Non-Muscle Invasive Bladder Cancer. I'm Kamal Pohar. I'm a faculty member at Ohio State University. I have two co-faculty joining me for the course, Dr. Fred Witjes from Radboud University in the Netherlands, and Dr. Ashish Kamat from MD Anderson Cancer Center in Houston. So I'm going to read a couple of notes from the AUA. They'll be brief at the start of the course, and then we'll put up the pre-test ARS questions. And in order to do that, you'll need to scan the QR code either on your phone through the app for the course, or you can do it from the screen when I put up the ARS questions. We have a couple of more people joining us. I'll just give a moment here and let everyone get seated. Good morning. Okay, some notes, please, to open the course. The course utilizes audience response questions. To participate, you'll need to scan the QR code located on the handouts near the entrance to the meeting room or on the screen. So I hope when you registered for your credit and so forth, you scan that code, or you can do it on the screen. The AUA 2024 Annual Meeting mobile app is available and is free to download. When you download the app, you'll be asked for a username and a password. Course materials are available on the AUA 2024 website and the mobile app. Use the email that you used to register. Your password is your AUA ID. You can also find it on your registration badge if you don't recall your ID. AUA policy states that all planners, authors, and presenters must disclose to the AUA prior to their presentations all relevant financial relationships with any ACCME-defined ineligible company, formerly known as a commercial interest. The AUA determines if the relationships are relevant to the educational content and mitigates any conflicts of interest prior to the educational activity. Disclosures or relevant financial relationships are posted on the AUA's annual meeting website, and a link is posted in the mobile app. An important detail, please remember to silence your cell phones. I better just double check my own to make sure I've done that. And no photos, video, or audio recordings are permitted during the course. Courses are selected based on evaluation results. We've done this course for several years in a row, and we're very appreciative of everyone's desire to attend, but the evaluations are critical for us to know, how valuable do you feel the course is, and for the AUA to know, is the course providing value. So I'd encourage you, please, to complete the evaluation form. We're very appreciative if you would do that. For every course evaluation that you complete, your name will be entered into a drawing for complimentary registration for AUA 2025, which will be in Las Vegas, Nevada next year. How do you evaluate the course? You can do it by selecting Evaluate through the credit claim process, or going to the AUA 2024 mobile app, click on the CME button, or go online and click on the CME page. So in order to complete the evaluation. Okay, we're going to start the course with a pre-test. And there are 5 questions. I'm going to read the answers. Again, please, the QR code that you scanned on the way into the room, or you can do it from the screen, is how you elicit your responses. Okay, so here's the QR code. If anybody needs it, I'll give you a couple of moments to please do it. If everyone's good, I see a few hands still up. That's good. I'll just ask one time, anybody need another moment on this slide before I move on? We're good? Okay. All right, polling question number 1. Which statements about TURBT is true? A repeat TURBT often identifies residual cancer in both high-grade T1 and high-volume TA bladder cancer, even when muscular propria is present. Response 2, a repeat TURBT is advisable if muscularis propria is absent in a visually complete TURBT for intermediate risk non-muscle invasive bladder cancer, in this situation defined as multifocal low-grade TA urothelial cancer. A complete or second TURBT is not advised for intermediate risk non-muscle invasive bladder cancer, as intravesical therapy is often just as effective and it's safer to treat residual tumors. Number 4, surgeon scorecards are generally not effective in improving quality of TURBT. The next slide is going to count down for 15 seconds for you to record your responses, and this will all come back to you at the end in the app, you know, when the course is over, as the post-test with the correct answers, polling results, and so forth. Okay, question number 2. Which statement is correct regarding best intravesical treatment for intermediate risk non-muscle invasive bladder cancer? 1 single post-TURBT installation of chemotherapy is sufficient. 1 single post-TURBT installation of BCG is sufficient. Consider a course of either chemotherapy or BCG. The best schedule is 3 years of BCG maintenance based on the SWOG schedule, the Southwest Oncology Group schedule. I'm going to move to the timer. There are 15 seconds to please record your response. Okay, question 3. BCG toxicity can be severe. The best way to prevent toxicity during a treatment course is the following: to administer BCG twice a week to complete treatment in a shorter time interval, to give ofloxacin or a fluoroquinolone 8 and 16 hours after a BCG installation, to give ciprofloxacin for 3 days before every BCG installation, to combine BCG treatment with an anti-tuberculous drug like isoniazid. 15 seconds for your responses. Question 4. So question 4 of 5, here it comes. Radical cystectomy should be advised as the next best step in the treatment of the following clinical scenario: CT finding of an enlarged pelvic lymph node during staging for T1 bladder cancer, persistent carcinoma in situ after completing induction BCG, extensive carcinoma in situ at the level of the trigone at the first TURBT, T1 urothelial cancer with micropapillary variant reported on both the primary and the repeat TURBT. And here are the 15 seconds. Please record your responses. And the final question is coming up. Which statement is correct about BCG-unresponsive non-muscle invasive bladder cancer? Bladder-sparing treatment options should not be recommended as guidelines favor radical cystectomy. The only FDA-approved checkpoint inhibitor is systemic pembrolizumab, administered for 6 to 12 months. It's Keytruda. Intravesical pembrolizumab, this is intravesical pembrolizumab, combined with BCG is a newly approved option. D, intravesical nadofaragene every 3 months during the first year is an approved option. That's Adstiladrin. And here come the 15 seconds. This is the last question, and we'll move into the course. I just want to welcome everyone again for attendance of the course this morning. The way the course will evolve, each of us have relatively short didactics, 10, 12 minutes or so on just topics that we think are very important, and it'll lead into several case presentations that we hope are very practical and that you see very commonly in your practices. We'll have dialogue, and certainly we would appreciate the audience, questions during the case discussions. Please don't hesitate to come up to the mic and so everyone can hear your question so we can interact together. So we'd like to make this an interactive course. Okay. So these are the course learning objectives. You have them all, on your course page. You also have our course materials that we shared with you. All of our slides that we're presenting today are in the course materials. Okay. So I'm going to focus on the importance of TURBT. There are my disclosures. So this is an important guideline statement that I think we're all, we're very aware of this concept, but it's the guideline statement from the AUA. At the time of resection of suspected bladder cancer, a clinician should perform a thorough cystoscopic examination of the entire bladder and urethra and documenting important features about what you visualize, because it becomes important, and I'm going to kind of emphasize that point of why that's relevant when you're conducting the surgery. At the initial diagnosis of a patient with bladder cancer, a clinician should perform a complete visual TURBT of all tumors when technically feasible. We can't underscore the fact that TURBT is a very diligent operation. Its impact on patient outcomes is important, and really working towards a complete visual TURBT is critical to a patient's outcome. And that's an important statement in the AUA guidelines. Why is that? Well, there's clinical evidence that demonstrates that the quality of TURBT or the completeness of TURBT can certainly impact outcomes. We're aware we generally feel that there are better outcomes after intravesical therapy for non-muscle invasive bladder cancer patients with a high quality TURBT. There's better outcomes, as we know, after radiation therapy. A radical TURBT or completeness of TURBT affects outcome in muscle invasive patients who are being treated with chemoradiation, and there's possibly higher PT0 rates after neoadjuvant chemotherapy after high quality TURBT. So several aspects of clinical care in bladder cancer where the TURBT can affect outcomes. It's difficult as an individual. How do I personally get better at performing a better operation? We have a number of studies and evidence at a much broader scale of how we can impact quality of TURBT amongst all of us performing the operation. So this is a government level, publicly supported healthcare system in Scotland. Kind of an important publication that the government and health authorities desired to try to improve quality parameters of TURBT and bladder cancer care. And parameters that we're focused on are ones that are pretty well evidence driven, using a bladder diagram, a single dose of intravesical chemotherapy post-TURBT, the presence of muscularis propria in the resected specimen. I know we're all highly focused on that parameter. We hear about it all the time, as well as an early or a repeat TURBT in individuals in whom that would benefit. So important parameters that the government invested in wanting to measure amongst all urologists in the country. And they put together a compliance program, and you could see the outcomes that they desire to measure, that if you implement these quality parameters, can we impact recurrence rates, understaging, and so forth. And so the evidence supported the kind of the busyness or the colorful diagrams on the slide are not that important. But what they're sharing here, there's years 1, 2, 3 that you see on the slides. And in the bottom diagram, that's hospitals A, B, C that are characterized by the volume of TURBTs that they performed. Lower volume hospital is A, medium volume hospital for TURBT is B, and a high volume hospital C. High volume was characterized as greater than 90 TURBTs a year, low volume was less than 60 TURBTs a year. The bottom line is as they measured their quality improvement parameters during the 3-year conduct of the study and looked at the deliverables of patient outcomes, It's over on the right on the slide. So a pretty big sample size. The delivery of perioperative chemotherapy was 67%. Recurrence rate at first follow-up cystoscopy was 13%. The rate of residual cancer in those that had a repeat TURBT was 33%, and the rate of upstaging to T2 was about 3%. So you can see pretty acceptable results, and what we would think is probably positive for impacting patient care. This just looks at who was performing the surgery, the red being a faculty member or consultant surgeon, and the black being a trainee. And what it demonstrates is that, I'll just share everything here, is what it demonstrates is that in hospitals with higher volume, trainees actually perform more of the operations. Kind of makes intuitive sense that in more of the larger volume, more training hospitals, trainees were performing more of the surgery. But importantly, the trainees were doing all types of TURBTs, including multifocal tumors, larger tumors. There was no difference in the selection of which cases were being done with a consultant versus a trainee. And the bottom line there is what I've kind of highlighted in the red, is that you see there was a difference between the consultant and the trainee when you looked at recurrence rates and residual cancer at TURBT. There was a difference. So quality, experience kind of matter in outcomes. But overall, there wasn't a large difference between whether a trainee performed the operation or a consultant when you look globally across the screen and in some of the lower volume hospitals. So at a government level, in a health system that's supported in that manner, you can see that quality parameters can help improve outcomes. And so obviously, you know, in the United States, we work in a different healthcare model. So there's another publication that I want to share here. So this publication's more than a decade old. There's a couple of publications like this along the similar concept, but it's creating a checklist. This is something we can all do. It's something that I implemented in my practice many years ago. You can have a checklist in the operating room that you use to document details. And why would you do that? Well, it's about putting in the information necessary for the accurate classification of the cancer when all the details are back and you sit down with the patient, documenting the completeness of resection of your surgery so you recall, you know, what happened during that surgery, and then also the safety of the operation. You know, was there any risk of perforation and so forth. So there are 10 items on the checklist, and you can see them all there. So the group put together a multi-institutional prospective study of 10 relatively straightforward, important and impactful parameters that one should strongly consider documenting in an operative report to drive those 3 parameters that I mentioned. And so here is before and after implementing the checklist. This is not about clinical outcomes. The group did not measure what the recurrence rates were, upstaging and so forth, but just documenting features that we know are important. And the one that I highlighted there, before and after implementing the checklist, these are fellowship-trained urologic oncologists, high-volume surgeons, and you can see before implementing the checklist, you know, parameters needed to improve, including knowing, did I completely resect all the visible tumor, yes or no? You can't remember 2 weeks later, 3 weeks later, sitting down with the patient, so to document that. Visualization during the conduct of the surgery. Did you visibly see that you were removing musculars propria during the resection? You can document that and have some dialogue with your pathologist if you feel differently when you get the report back that you were pretty convinced you included muscle in the specimen. You can go back to your report and you can see how much that improved. And there's many parameters up on the slide, that 10-item checklist, relatively simple thing. This is kind of drilled down more to maybe an institution level, a group practice, you know, so what can we do maybe as a smaller group then? You know, again, it's maybe difficult as an individual surgeon. You know, there are things certainly you can do like the surgeon checklist, but this is a scorecard given to surgeons. So this is from Northwestern University. So up on the slide, it's very busy. It's not that important, all the details on the slide, but there are several surgeons. There are 10 surgeons performing TURBTs at the institution. So they looked at rates of residual disease, muscle in the specimen amongst the surgeons, and they provided feedback in a positive way that, you know, here's our group, You don't know which surgeon you are on the group, but these are kind of the outcomes amongst our group. So they implemented a checklist about parameters of having muscle in the specimen. Did you give perioperative chemotherapy? Did you document completeness of resection? And they introduced their scorecard. And what they found is that the rate of presence of muscle in the specimen, it went from around 30-some% to just a little over 50%. So you can see that even with a scorecard and before introduction, it's not always easy to have muscle in the specimen in every case. And so even in a high volume center implementation of a scorecard, there still were several patients that didn't have muscle in the specimen. But the deliverable was post scorecard initiation. You could see that there was a significant reduction in recurrence rates at the first follow-up cystoscopy. So it made a difference in their institution. So certainly there are different ways to impact TURBT, and I think it's really important that we all focus on that concept. Now, AUA guideline, when should you do a repeat TURBT? I think two up there are practice patterns that we all utilize. I think we can all endorse. There's a wealth of information that supports, in which situations should a repeat TURBT be done. Obviously, when there's residual tumor, if it's safe and feasible to remove residual tumor after the first TURBT, it's important to do a complete visual TURBT. The second is T1 disease. We know there are multiple reports, there's guidelines throughout the world that strongly suggest that in a patient diagnosed with T1 bladder cancer, whether muscle is present or not, that a repeat TURBT is advisable because of the potential high risk of leaving residual microscopic or visible disease and the potential risk of understaging to muscle invasive disease, whether you have muscle there or not. And so this just emphasizes the same point I just brought up. The final bullet I want to bring up, there's a couple of publications that also demonstrate that it can change your treatment plan in up to a third of patients. The repeat TURBT with the additional knowledge might change your plan of action. You might move on to a radical cystectomy. You might change the paradigm of the manner and how much intravesical therapy are you going to administer or what agent. And this is a more of a population global level study of looking at almost over 1,000 patients. It just provides at a population-based level that a repeat TURBT had a positive impact of reducing progression to muscle-invasive disease. That's repeat TURBT having been done within 3 months of the initial TURBT, and it had a favorable impact on cancer-specific and overall survival. So, repeat TURBT is important. It impacts outcomes, and there are patients that certainly would benefit. So I'm going to move on. If I could go back to the whole, I appreciate you running all that before I mess it up here. So we're going to get started with the cases. And so for those of you who walked in a little bit after we started the course, I'm just going to reintroduce a couple of faculty members. Dr. Fred Witjes from Radboud University in the Netherlands, and Dr. Ashish Kamat from MD Anderson Cancer Center in Houston. And so I'm going to open up the first case presentation.
And you're from Ohio, obviously.
It's true.
He doesn't want to admit it.
Okay. That's not true. Okay. So again, please feel free to come to the mic. It's very interactive. Don't be shy. It's early in the morning. So if you have questions about the case, you feel differently about it, that's great. Let's talk about it. I hope these cases are...
Kamal, can I have a question?
Yeah.
Are there T1 patients where you would not consider a re-TUR?
Yeah,
It is a bit controversial, eh?
Yeah, it's, I'm glad you bring that up as you ask the questioning. So it is controversial. There is some controversy over that. So certainly the guidelines recommend that you strongly consider with a grade B recommendation. That's updated by the AUA in 2024. But there are publications that demonstrate in a smaller tumor, solitary tumor, surgeon is confident in the completeness of TURBT, the completeness of the radicalness of resecting the muscularis propria, because I think that's important. A pathologist is just going to look at the presence, and how much muscle you truly removed at the base of the tumor. That's in your hands to actually have confidence, the radicalness of your TURBT. So I think there are selected cases one would consider that. I know that Dr. Witches feels that way. Dr. Komet, how do you feel about all T1 patients having a repeat TURBT? Are there ones that you might consider not doing that approach?
So this topic comes up as a matter of debate very, very often, right? And in really, truly expert hands like Fred's, I think the risk to the patient is extremely small of missing something or not being able to detect residual disease. But if you look at population-based, and this is across academic centers too, the risk of missing muscle involvement is about 15%, even if you had good muscle the first time around. And it's about 45-50% if you did not have muscle. So it's clearly you're going to be treating T2 patients in 50% of the cases without muscle and 15% of the cases with muscle. It's not, I don't think it's necessarily because the urologist is not as skilled as Dr. Witches is, but there's something to do with the handling of the pathology, how it goes to the pathologist. So if you resected it, for example, if I resect a tumor, I'll send the base separately. If I'm thoroughly confident that there's no, it's T1A and I got muscle, I may not take that patient back to the OR. I fully agree with Fred. But the guidelines all state, take the patient back for T1, and just as importantly, if any of you are wanting to enroll your patients on clinical trials, you will have to do it anyway because it's included in every clinical trial. So yes, with some exceptions, T1 high-grade disease, in your mind, just counsel a patient. We need to go in and make sure there's nothing left behind.
Yeah, I like that term, maybe the few exceptions. If I wouldn't mind, if everyone could raise their hand, does anyone not do a repeat TURBT for T1 bladder cancer in selected cases? Good. Great. Yep, please. If you wouldn't mind using the mic, that way everyone can hear your question. Thanks very much.
It looks like it depends on the surgeon experience. I've been doing it for the past few years because of the guidelines and because of being scared of medical legal issues. And so I didn't have a single one where there was a tumor left over for the past few years since these guidelines came. So I was just wondering, is it just because of lack of experience of some of the new surgeons and what have you, and it has to be tailored to your case-by-case basis, or does it have to be just as, just everyone should do it? I'm not really sure.
Yeah.
But I didn't have a single case.
I think that's important. Just look at your own results. I did the same some years ago, the first 300 patients with a T1 or something like that. And indeed, the percentage of upstaging was extremely low. Residual tumor was very low. I realized that if you do re-TOR, you postpone effective therapy for 2 months, which is, also a disadvantage. But anyway, in any case, if you're in doubt, do a re-TOR.
Yeah, I think that's a good message. If there's any doubt, to do a repeat TUR. Okay, I'm going to move on to the first case. I'm trying to advance this slide. If you wouldn't mind, if we could go back one. Thanks for that. Thanks, I'm not sure what I did. Okay, so common history in a bladder cancer patient. 67-year-old, male, hypertension, hyperlipidemia, prior cigarette use for many years, evaluated for gross hematuria. He has stable lower urinary tract symptoms characterized by mostly storage symptoms. He's been on tamsulosin therapy for 3 years. CT urogram was done for the gross hematuria workup. Several filling defects in the bladder. Radiology report suggests possible clot. Urine cytology was submitted, suspicious for high-grade urothelial cancer. Office cystoscopy was performed. I want to have a raise of hands. Anyone based on the CT scan, filling defects, would everyone do an office cystoscopy, or would you go straight to TURBT in a case like this? Raise of hands, who would do an office cystoscopy all of the time before proceeding with TURBT, regardless of the CT findings? Anyone wouldn't? I think it's about half-half. That's why I asked the question the other way. Yeah, I mean, there's a lot of variation. I think even on the panel there seems to be variation.
I mean, if it was a clear tumor in the bladder, I would not do an office cystoscopy.
Okay.
I would. I'd like to see the tumor. I'd like to see whether it's invasive. If you've got experience, you can very nicely predict whether it's invasive or no. It will influence your planning for the operation. So I would love to see the tumor.
So Fred, let me ask you on that, just to elucidate for the audience. So if you on CT scan see a tumor that's 6 centimeters, looks invasive or not, and you do a cystoscopy and it looks invasive or not, how do you change your planning for that patient for the OR? Like, why could you not look in the bladder at the time of your scheduled TUR and then make that decision there? Like, what do you do differently?
Well, sometimes it's not only tumor but a lot of clots, and that makes the TOR maybe a little bit easier or difficult for the timing of the for the timing. It's important, and to be honest, currently we do a lot of MRIs, and that also helps you a lot with predicting what kind of tumor it is and how intensive the TOR has to be.
Maybe I'll just share, again, a small cost issue here. I mean, if you perform the operation with blue light cystoscopy routinely, you have an invasive cancer. The blue light cystoscopy is not likely to impact that patient's outcome much. So, I often don't do a cysto in patients where it's obvious on a CT, but I'm just listening to the interaction. Also, perioperative use of intravesical chemotherapy. Not that you don't have to administer it if you see an invasive tumor and you've called for it from the pharmacy or you have the drug available. But if you knew there was an invasive tumor going in, you wouldn't administer it, in the perioperative period. Okay. So some details now about the surgery. So EUA essentially unremarkable other than an enlarged prostate. The actual endoscopy, the urethra is normal, prostatic urethra is normal. So 8 papillary tumors are identified in the bladder. And you could see the locations. They were in several sites, and they ranged in size from 1 to 3 centimeters. A complete visual TURBT was performed, and they were submitted as 3 separate specimens. Dr. Kamat, Dr. Wichis, it comes up with me and my residents often. There's a balance between the practical conduct of the surgery and doing what's safe and kind of, getting the job done in a way that's safe versus, separating the tumors from the different regions and submitting it to pathology for the potential prognostic benefit, possibly. How do you feel about that situation? Like, do you strongly feel that individual tumors or clumps of tumors should be resected separately and submitted that way, or just submitting everything en bloc in one specimen container is sufficient?
It depends a bit, if it's a very low grade, 10 small low grade tumors, I would resect the largest one, do also sampling of the border and the base, and probably coagulate the rest. If you have, let's say, 8 T1 looking tumors, I would probably at least do a few separately in containers. By the way, this certainly looks different from what you saw on CT.
Say that, explain that in more detail.
You've got 8 papillary tumors from 1 to 3 centimeters, and if you look at your previous slide, the CT had sort of a lump. So
I think CT had multiple filling defects.
Okay, sorry. I did
Suggestive of clot.
Okay.
Dr. Kamat, any
Yeah, here I think it really depends upon your pathologist, right? So if your pathologist at your institution gets a bunch of tumors in one, they don't necessarily look at all the tumors. And that's just a fact. They will look at a representative sample. It's kind of like lymph nodes and radical cystectomy. If you send all the lymph nodes together, your count is lower. You send the lymph nodes separately, your count is higher. Not because suddenly magically the patient has more lymph nodes, the pathologist looks more carefully. So if your pathologist is someone who needs to have separate specimens so that you get a better result and your patient gets a better result, I would strongly urge you to send separate specimens. Otherwise, doing it like you did here in regions is how I do it. Because otherwise you'd be sending sometimes 30 specimens, right? But region, you expect the field effect on the right wall should be similar to the field effect, so long as it's clumped together. But the pathology part is very important because I've had patients who've been referred to me where the urologist said they saw 10 tumors in the bladder, send it to the pathologist. Pathologist literally read 1 tumor, send the patient to me, and then we always call for slides to be sent to us to re-review. And when we reviewed it, it was muscle invasive disease, but the invasive tumor had not been looked at all. So learn what your pathologist does.
Yeah. Yeah, please. Do you mind using the microphone that so everyone can hear you? Okay, good. Yeah, so the comment was CT scan is, filling defects are often suggested to be clot and. Yeah, I guess the sensitivity of CT, is not the best, to diagnose all bladder tumors, especially in a multifocal setting. I'm sorry, you said that you see this type of report. You don't. Yeah, good. Okay. So, Dr. Richards, I'm going to take you back to the clinical scenario. So you saw the details of the 8 tumors in the different regions. Would you give perioperative chemotherapy to this 8 tumors, 1 to 3 centimeters in size? Would they benefit from a I know you're going to talk about it more during your part of the program lecture, but what do you think? Would you give it?
No, you also had high-grade cytology, so this almost certainly is a high-risk tumor, and then one installation is not really very useful, apart from the fact that if you have done on 8 spots in the bladder TOR, you might have a subclinical perforation, so I wouldn't do that.
Dr. Kumar?
Yeah, if the cytology was not positive for high grade, clearly, then I would likely do perioperative chemotherapy. But because the cytology is positive, I'm suspecting this is going to be a high risk tumor that comes back, and then high risk tumor, we know that there's not that much benefit for perioperative chemo.
If I could expound on the concept a little bit. So, things have evolved over time about administration of perioperative chemotherapy. There was a time where meta-analyses demonstrated all NMIBC patients or suspected patients should get a dose. I think based on the most recent evidence and publications, we kind of focus on the EORTC score. I don't know if everyone is familiar with the EORTC scoring system, but if I recall correctly, it's if the score is greater than or equal to 5, the benefit is not as high as those in whom the score is less. I didn't do the calculation on this patient. I'm just thinking it out loud. I think his score is probably a little over 5.
Sure.
So what do you guys think about nitpicking the detail of the EORTC score, whether it was low grade or high grade in the end, and using that to make a decision in the operating room?
You got to keep it simple, right? I mean, that EORTC score is phenomenal. That's great, but it's good for research and not the other kind of things. The simple way to think about this is if it's a high grade disease, it's high risk. If it's high-grade disease, more than likely you're going to need something more than just what you did at TURBT and save the perioperative chemotherapy. If it's a low-grade disease, consider perioperative chemotherapy. If you start putting the scoring system into play, I'm telling you, the workflow is too busy for too many people.
I like that. That's why this is a practical course, and that's a practical. Who in this situation would give the perioperative chemotherapy? Raise your hand, please. Who routinely gives the chemo in this patient? Okay, so not many. Is it because of the number of tumors? Is that why? I see a lot of heads shaking up and down as yes. Okay. All right. Sorry, one slide back. Thanks for that. Dr. Grant, enhanced cystoscopy, specifically blue light cystoscopy or narrowband imaging at the time of conduct of TURBT, if that's available to you, how much benefit is there in this patient, if any?
In this particular patient, there is benefit. Absolutely, no question about it. I mean, you can show a photo trial, which I got a sneak peek of, and we can debate that too. But you have to think about, why am I using whatever tool I'm using, right? And what you're trying to do here is use enhanced optical cystoscopy, whether it's blue light, NBI, whether it's your high definition, camera, whether it's a SPECE system, whatever you have at your place. If you have blue light, use it. If you don't, use narrowband. But you're trying to detect tumors that you may not see with white light, number one. You're trying to detect CIS because this patient has a positive cytology, which will completely change your management paradigm. So in this patient, at the time of TURBT, the optical enhanced cystoscopy, whatever you have, use it, will help.
Any other comment?
Totally agree. Absolutely.
In the room, everybody, raise your hand if you're using some form of enhanced cystoscopy in the operating room at TURBT, whether it's NBI, blue light. Good. It seems like the majority are. I'm glad that if there's availability, naturally, if you don't, you don't, I guess, no choice. Okay. The photo trial, I am going to put it up. There's a large body of evidence, trials about enhanced cystoscopy, detection benefit, recurrence benefit. But the photo trial, it's a pragmatic clinical trial from the UK with longer term outcome measured at 3 years. Really didn't demonstrate a difference in improvement in recurrence rate between white light TURBT versus blue light TURBT, randomized pragmatic trial. Dr. Clement, comments about the trial? What your view of that based on all of our enthusiasm, all 3 of us, the group. I'll put up the AUA guideline.
No, if you go back to the trial, that way I can comment.
Could we go
on it a
back
little
one
bit.
slide, please?
I've had multiple discussions in private and public forum with Rakesh here, who's the PI and the primary author of this study. What throws some people off that is it's published in New England Journal of Medicine. It's not. It's published in New England Journal of Medicine Evidence, which is an open source publication, which is completely different impact factor, right? Number one.
None.
Sorry?
None.
None. Oh, zero impact factor. Yeah, which is completely different. No. So I don't want to make that quite that public, but yes, it has no impact factor. But the issue here is that we're looking at blue light cystoscopy. There's so much evidence out there to show in prospective multi-center studies that it benefits, right? In this study here, it did not show benefit. Why is that? Well, it's what you did today was expected to predict outcomes as to what's going to happen in 3 years with bad treatment in between. A lot of these patients who should have gotten BCG did not get it. A lot of patients who should have gotten chemo did not get it. So they use something here, and you look at the curves. Initially, they separate, right? So initially, it helps the patient, and then later on, when the urologist in this case is ignoring the data and not doing the right treatment, what you did a year ago is not going to help. So there's a lot of problems with this study.
Well, two major problems are, because we wrote a comment on that in European Urology, is that they started off with 600 patients and almost 200 were not eligible for the trial. So they excluded 1/3 of the patients. And the ones who got blue light had much less adjuvant therapy as the ones who got white light. So there is a major difference between the two groups in adjuvant therapy.
Yeah.
I think that's very important to realize.
And one other point I'll just add to that is, these longer term outcomes are really not impacting, they're not really assessing the impact of the technology. This is related to epithelial field cancerization. I mean, that's what we're talking about here, longer term outcomes. It's about the recurrences due to the field change effect. And so clearly the technology is not likely going to benefit that concept of why recurrences happen. Okay. Let's see. So the AUA statement, you can see it there. It's a grade B recommendation for blue light cystoscopy, that if it's available to you, the conduct of using at the time of TURBT is important, and narrowband imaging, a grade C recommendation. So if we have it available, as we've been discussing, important to use it if you have it available. Anyone frustrated with the technologies? Anyone want to raise their hand that you realize you would like to use it, the evidence, but anyone frustrated by the concepts, or no? Sometimes I'm frustrated by it. I could tell you the truth, but okay.
You want to talk about it?
No.
we can have a therapy session.
Just buy me a new machine. That'll fix it. Okay. All right. So here's the pathology. Okay. So the 3 specimens were submitted separately. Okay. So one area in the trigone, high-grade TA urothelial cancer with carcinoma in situ, muscle present and not involved. The tumors on the posterior wall, high-grade TA urothelial cancer, muscle present and not involved. The 3rd specimen on the right lateral wall, high-grade TA urothelial cancer, no muscle present. So 2 of the 3 specimens, muscles present. I'm going to move to the next slide. I'm just going to focus on the second bullet. We've already kind of talked about the first one a little bit. Dr. Witches, repeat TURBT in this patient?
Well, that's one of the questions I had for TA. I think in this case you had twice the muscle present and negative. In the 3rd, you did have lamina propria, which was negative. So again, not because this patient clearly needs treatment. I think I would go, depending on whether I think I did a complete resection, I would go for intravesical therapy and not for a PT or RBT.
So patient did have a complete visual TURBT. Dr. Kamat, repeat TUR?
No, I agree. If the patient had a complete visual TURBT and it was documented and you trust the surgeon, if it's someone else that did it and you got this patient, you have to know, do you trust the surgeon too? Then I wouldn't do it. But if I would ask my pathologist, are they saying there's no lamina propria invasion because there's no lamina propria? In that case, I would go back.
Yeah, sure.
If it's really a superficial pluck, which I've seen. But if they're actually saying there's lamina propria present and it's not invaded, then I'd not go back.
Anyone in the audience feel differently? Repeat TURBT in this situation? If you've done a complete visual TUR, everyone's comfortable? Okay. All right, so I'm going to get off the stage. I'm sure you're looking forward to Dr. Witches coming up. So if you could please give me back the controls. Thank you very much. I will put your slides up right
Okay, Kamal, thanks very much. I think we already, I'm going to talk about risk groups and complication management. And we obviously already talked a little bit about the risk group, so some of the things already have been discussed. Here are the learning objectives, so look at the risk groups and also when there is BCG shortage and what to do with toxicities of chemo and BCG. Some conflicts of interest not relevant. I think we emphasize enough, so do a good TUR. Intravesical therapy cannot compensate for an incomplete TUR. It's one of the questions also in the poll. And don't forget the prosthetic urethra. So I always tell my residents to be, you've seen that the quality indicators, do a good TUR. There are some consultative alternatives, especially in the patients that you know that had low-grade TA tumors. You can do an office fulguration, which is both in the American and the European guideline, and even which is now in the European guideline, not yet in the American guideline. And that's something I do, is sometimes when you see a small tumor, do active surveillance. We do that in prostate cancer. We do that in kidney cancer. Why not do that in small tumors in bladder cancer? So that's something I really advise you to consider. Here are the risk groups. I think we've discussed that a little bit. Low grade, obviously, low risk, low grade tumors, solitary, primary TA, small, and PUN-LIMP, which I don't see a lot, maybe once a year, not more than that. High risk, the other end is also clear, high-grade TA, recurrent, large, multifocal, CIS, BCG failures, histological variants, you see them more and more currently, lymphovascular invasion, and prosthetic urethral involvement. Those are all things we realize, and I agree with Ashish, that's your gut feeling, that's not good. So that's really a high risk. And intermediate is a little bit the stuff in between. With one remark, let's say low-grade T1, my pathologist claims that doesn't exist. I tend to agree. And high-grade TA, small, is in the intermediate risk. And there was yesterday a very nice session, 2 presentations, one saying that high-grade TA is intermediate risk because it doesn't have a bad prognosis. The other presentation, also a large series, high-grade TA was just as bad as high-grade T1. So I don't know what the answer is, maybe we can discuss that. But that's not in the European guideline. In the European guideline, all high-grade tumors are high risk. Realize if you do use the European system, so the new European guidelines, and Ashish has published that, and there was also again a abstract yesterday discussing the same with the same results, there is a real overestimation of the risk of progression. The reason is that the data set is without a lot of BCG, without re-TUR, it's an older series, and if you treat patients according to the current guidelines, I think that the risk of progression, as you can see here, is much lower than that you would calculate with the EORTC or EAU risk calculator. This is for progression. We saw yesterday that this is the same for intermediate risk patients. Recurrence is okay, but realize that the progression data from the EU guideline calculator are a little bit overestimating. Important for your patient, important maybe also for trials. You have to realize that. There are additional bad factors for high risk, and one of the things that I'm already amazed about for years that is not in guideline is the T1 subclassification. So a small, superficial T1 definitely has a better prognosis than a large invading T1, which is almost a T2. Ashish also mentioned that, and I think that's really something that you should ask your pathologist to look at, and then the rest you know, lymphovascular invasion, CIS, etc., etc. But also make sure that you ask about the T1 subclassification. Any questions or remarks on the risk group, maybe from the faculty or from the audience? If so, we can look at that.
Fred, I just want to emphasize a point that you already made, and we've published on this, and the IBCG recommends it. If it's a high-grade tumor, consider it high risk, because that's how you would treat the patient, right? All these nuances of intermediate and all of that. And again, if it's less than 3 centimeters, it's intermediate risk. If it's 3.1 centimeters, it's high risk. I mean, we all know 3 centimeters, 2.9, 3.1. I mean, it's hard to differentiate. So I agree with you. I just want to emphasize, I too, if it's high grade, think of them as high risk.
You know, size is very subjective. You use your loop and you think, well, it's around this or that. That might be an advantage of a CT, by the way, which I don't use. Okay, let's go to intravesical therapy. We've done the diagnosis, we've done a good TUR, we know what it is, and we're going to treat according to the guideline. I think a low risk, it's quite simple. Both the American guideline and the European guideline and the BAUS guideline and the French guideline, I've looked at several guidelines, are clear. You have to give a post-operative installation of chemotherapy. And of course, not BCG, that's life-threatening. And that usually is enough. So in low-risk patients, 1 instillation of usually mitomycin C, that's enough. You see in the bottom of the slide, there is a large updated systemic review of Richard Sylvester, published in 2016. And you see all over in low and intermediate risk patients, there is a reduction of around 15% absolute reduction in the recurrence rate. So with 1 instillation, that's really something that is valuable. You see here the trial done by at Messing with gemcitabine. Also, again, a very clear reduction in the recurrence rate. And in red, you see that if you look at the really low-grade patients, the reduction is even 20%. So for sure, single post installation is useful, and it's safe, and it really helps your patient. Beware, it's not always done. I realize that. I realize that in America there are maybe some logistical problems. Patients are in and out in the same day. It's a daycare procedure, so that might be a problem. Maybe you give it on the recovery room, you give it on the OR, you give it on the ward. So I realize that there are logistic problems. Some people doubt about the efficacy. I don't think that's correct. Some people are afraid for the safety. We did a large study in the Netherlands. It's really safe. Also, if you look at the data from at Messing, the toxicity, the side effects are really very, very low. So it's safe and effective. So make sure that you do that. Make sure that there is no perforation, because if you have so, you have a nasty problem. The photo you see on the right top is a patient I saw with 1 instillation. He had a perforation, so he ended up with a shrunken bladder and a fistula, so we had to do a cystectomy for a T8 tumor after 1 instillation. It's safe, it's effective. Do think about alternatives. Again, there was a nice study yesterday from China looking at that. So if you are a little bit afraid of, for example, a perforation, or if the patients are allergic to, for example, mitomycin C, you can also give 24 hours of saline irrigation of the bladder, which also sort of takes out all the malignant cells that are still floating around. By the way, I don't use mitomycin C, I use epirubicin, because mitomycin C typically gives you those calcifications in the bladder, which are without complaints. That's true, but you see that much less with epirubicin. Intermediate risk, again, quite clear within guidelines, single post installation, and then a course of chemotherapy or a course of BCG. And the choice depends on whether it's really a lower part of the intermediate risk or the higher part of the intermediate risk. BCG obviously is more effective, less recurrences, but it's also more toxic, and we've had some availability problems, so that might be a reason in intermediate risk to go for chemotherapy. Of course, you can also use this, what has been done by the International Bladder Cancer Group, differentiate the higher risk, intermediate risk, from the lower risk, intermediate risk, and you can use the number of tumors, the size, if you can do that, the timing of the recurrence, the frequency of the recurrence, and the previous intravesical treatment. And you realize the more negative factors you have, the higher risk the intermediate risk patient is, so you probably would go for BCG, and if you don't have those factors, it's almost a low risk patient, you might go for intravesical chemotherapy. High risk advice, again, also quite obvious. It's a course of BCG with maintenance. That's the SWOG schedules used everywhere in the whole world. So I think there's clear advice on that. This is a very large EORTC study, which is interesting. It compares 4 schedules: 1 year full dose BCG, 3 years full dose BCG, 1 year 1/3 dose BCG, and 3 years 1/3 dose of BCG. And actually the progression was the same, cancer-specific mortality was the same, toxicity was the same, which is a bit funny, and there was only a very small difference between the highest, most intensive course and the least intensive course of 10% of recurrence rate. So you can play a little bit around with your dosing and schedule of BCG. If you have a very, very high risk, and Dr. Kamat will talk about that, then I think we all should consider at least cystectomy. For example, variant histology is something that I always am a little bit afraid of, and for me one of the reasons to think about radical cystectomy. BCG relapse and salvage systems, regimens, and that has been changed a little bit in the 2024 guideline edition from the Americans. You see now that there are intravesical therapies mentioned, nadofaragene, and also gemcitabine, docetaxel, and pembrolizumab. So used to be BCG relapse was all clinical trials, but now there are a few options that apparently are realistic options to consider. And here you see the data on gemdosi, and again also this AOA you see several studies on that, and there is a trial running, gemdosi versus BCG. All we have currently is of course retrospective, but apparently it's quite an effective schedule, and to my surprise, because I've also used it, it was not as toxic as I thought. It's very well to do for a patient. Other options, and you know those, it's also again discussed, FDA approved is pembro and nadofaragene, and there is a super agonist N803, durvalumab, atezolizumab, prolonged exposure. So there are a lot of new stuffs around, and please keep track on that, because I'm sure that we will treat those patients, the higher risk patients, differently within a few years than we do currently. Take-home messages for treatment, starting with the good TUR. Single positive is effective and enough in low-risk patients. Intermediate risk patients, an adequate course of chemo or BCG, and maybe use the different risk factors. High-risk patients, or with CIS full dose, maintenance BCG, and the highest risk patients consider, of course, cystectomy, and keep on track of the new trials. Complications, this was a very nice article that was published a few years ago, so make a picture, because if you want to know something about complications of intravesical therapy, this was a very good manuscript. If you look at intravesical chemotherapy, of course you have chemical cystitis, that's clear, and the only extra side effect of mitomycin C is skin allergy, and you see that in between 5 to 10% of patients, and that's of course a reason to go to another drug, because that's a very nasty side effect. You see a very nice schedule. I won't go into detail, but the manuscript that I mentioned has a very nice algorithm for mitomycin C treatment, which basically means if you have some side effects, you should use anticholinergic drugs. And if there are more, or if you have allergia, of course, you have to go for another treatment. And it also includes sites like post-DOR and office fulguration, and before and after 48 hours of the installation. So it's a very complete overview of what you could do with mitomycin C toxicity. Toxicity of BCG is more. Of course, you are giving the patient a urinary tract infection, and you see that in around 1/3 of the patients you will have some general symptoms, malaise, some bladder irritation, some hematuria. It goes down after the few days after installation. So we do our installations on Wednesday, and then Thursday patients are not very nice, and then after the weekend they're doing well again. And then of course they get a new installation, and you see on the right part that per installation, at least in the induction course, the symptoms do increase a little bit. So make sure that you do that well. How can you prevent BCG toxicity? Maybe dose reduction. I talked about the 1/3 dose. Stop maintenance earlier, maybe 1 year, 1.5 years. Decrease dwell time, less than 30 minutes might be an option, and then shorten to 2 maintenance treatments instead of 3. There are some studies that looked at that, and apparently you don't lose that much efficacy, but you do have less side effects. If you do antibiotic, don't use INH. Has been done in a very large EORTC trial, and it doesn't reduce toxicity for the bladder. It only increases toxicity for the liver, so that's not a good choice. Ofloxacin, given, let's say, the evening of the installation, the next morning, 6 and 18 hours after BCG, really improves tolerability to BCG. And the same goes for plurifloxacin. So that's something to consider. And it's not ciprofloxacin, by the way. If you have some tox, again, make sure that you don't give too much BCG. If there is a real urinary tract infection, of course, treat that. Otherwise, stop or postpone the BCG treatments. Start fluoroquinolones around the admission, like I told you. And if it's getting worse and worse, of course, you should try to give anti-tuberculous drugs, and of course, stop instillation therapy. Because you know, it can be very severe. I've only had 1 death after BCG from a very systemic infection, but you know, I'll never forget that. So it can be very, very severe. Let's look at contraindications. Absolute contraindications are, of course, mucosal integrity loss, like within 24 hours after TOR. Don't give BCG then. And of course also an allergia. Relative contraindications is immunocompromised patients, specifically the ones with kidney transplantation. We have a large kidney transplantation unit in Nijmegen, and I've treated patients with BCG, and if you control them well and again make sure there is no perforation, etc., it's doable, and they don't have much more complaints than patients that are not on immunocompressed patients. And of course, prior tuberculosis also, we don't see that a lot anymore, but when I started my career, almost all the patients that are treated have had tuberculosis. Now you don't see it a lot, but that's a relative contraindication for BCG, so you can try that. Take-home messages: toxicity and intravesical therapy. If you give chemotherapy, know the side effect profile of the different drugs that you're using. Treat or prevent them when possible. And of course, mitomycin C probably has the most. It's a very effective drug, but I guess it also has most side effects. BCG toxicity seems to be less severe and frequent than reported decades ago, but it can be life-threatening, so keep track on that. Know and recognize the symptoms, know treatment options, and know to prevent or decrease the side effects. Thank you for your attention.
Fred, if I could just ask for a moment, the schedule that you would recommend, for treating toxicity with steroids plus or minus an antihistamine, so how would you prescribe that? Is it a tapering steroid schedule? How long the duration? What antihistamine? How long do you use it for? Can you comment on that?
So it depends a bit on the severity of the side effects, obviously. If it's a lot, you can do tapering indeed. And we usually give that a few times, and then usually the side effects disappear. And then the most important question is, are you going to repeat a BCG, which we usually don't do, because I guess most will get the same problems again. And antihistaminic drugs, not so much. That's not the most important part of the treatment.
It's easier in the US because you just use the steroid dose pack.
Yeah. You've got a question?
Yeah. A comment on T1 low grade, sir. Does it really not exist? We had a review of all T1 tumors at our center. The pathologists were not convinced that at least 5% of the patients, they were still T1 low grade, is what their impression was.
At MD Anderson, it's extremely rare. We find it, but it's extremely rare. Rare enough that when we find it, even very experienced pathologists will ask their other geopathologists.
If we ask them for persistently, if we ask them, they might change it to high grade, but their initial first impression was that it was a T1 low grade indeed.
It's extremely rare.
So my pathologist did a large review of 2 AURTC trials, I think more than 1,000 patients. He didn't find any T1 low grade.
Okay.
But then he also said, I'm also just a pathologist, so there is also a subjective part.
There is an ongoing debate amongst the pathologists as well, I think.
I think the debate is not more about the low grade part of it. The debate is
T1.
Is the T1 looking
substance.
because the loop cut the tumor in such a way that to the pathologist it looks like the lamina propria is invaded versus the tumor was pushing the lamina propria.
Okay.
I think that's the debate. But in clinical terms, T1 low grade, we just consider it doesn't exist.
Okay, thanks.
Hi. So in regards to managing BCG toxicity with antibiotics, there are some older series from the 90s suggesting that you might have less efficacy if you give them antibiotics. So is it your feeling nowadays?
A good question. So let's differentiate two things. If you have BCG treatment, but the culture that you're taking is E. coli or something, then of course you treat the E. coli. And in that large EORTC trial, the anti-tuberculous drugs did not influence on efficacy of BCG. And also the trials with ofloxacin and purifloxacin didn't, fortunately, influence the efficacy of BCG treatment. It does something on the side effects. And obviously you give it only twice, so it's not 20 years of antibiotic treatment.
And the timing is very important.
And the time.
Yeah, you don't want to give it too soon because then you'll kill the bacteria and decrease the cytokines.
Hi, good morning. Any thoughts on your maintenance BCG schedule? Does everybody use the every 3, 6 months, 12 months, or does anybody use monthly?
So basically, I tried to do at least the first year of the SWOG schedule. And then obviously we had a BCG issue, I think around 3 or 4 years ago, then we shared patients. So you try to get in 3 at the same time so that the pharmacy can make out of 1 vial 3 installations. And that time I tried to stop also after 1 year and not try to go further. With one exception, CIS is something that you really should treat with full dose BCG for 3 years. But if you look at that EORTC trial, and there's seen more trials, You can play around a little bit with the dose, so it shouldn't always be full dose for 3 years.
Yeah, and you're referring to different maintenance schedules, right? So in the United States, there were 2 schedules that were tried out 25, 30 years ago. Monthly BCG, no benefit. And the other schedule that was tried out, I think at WashU at that time, was 1 installation every 3 months. Again, no benefit. The third schedule that was studied in Spain by João Palau was 6 weeks, then wait 6 months, do another 6 weeks. Again, no benefit. So the only schedule that has actually shown benefit is the SWOG study. 6 installations, wait 6 weeks, give 3 installations, wait 3 months, give 3, and then every 3 months for 6 years. In our guidelines in North America, officially suggest that you should try to taper and decrease the dose as soon as possible because of the BCG shortage.
Okay. Another quick question. Any thoughts on using monopolar versus bipolar on your resections? Does that make a difference in the tissue that you're given to the pathologist?
Again-
We often get that, using monopolar, sometimes they won't be able to tell because of the heat or the cautery effect, and so just wondered if you had any opinions.
Good question. My pathologist doesn't really see the difference between monopolar and bipolar. It's said that bipolar gives less operator nerve kicks, which I guess also is not a major difference. If you really want to help your pathologist, do an en bloc resection. And you can only do that, of course, in smaller tumors. That's for the pathologist, great. And to my surprise, that also does not affect on recurrence rate, which you might think, but it doesn't.
Yeah, Fred, I think there again, and it was brought up earlier by someone in the audience, it really depends upon the experience of the surgeon. Because I have walked into a room somewhere where people are using the monopolar and it's clearly burning the tumor. The pathologist can't see anything. So it's technique, but there's not that much difference between the two. Bipolar is cleaner, but not so much so that you should switch.
Yeah, but I think that if you have it available, I think you should probably use bipolar. If you don't have it available, I think, monopolar is fine for the comments we brought. I use monopolar. We have both available, but I know several of our cancer faculty, use bipolar, but I don't. Okay. Should we continue with some cases? Thanks very much for that. I'm going to go back to the case that we left off, and just as a reminder, this was the pathology.
Oh, okay. Yeah, because I don't.
Sorry, I'm having a hard time advancing the slide again. Thanks for that. Okay, so just as a reminder, this is the pathology of the patient we were discussing with the 8 tumors. We had some dialogue about a repeat TURBT. The consensus was no. Let's carry on based on the platform that Dr. Witches put together, and let's have some practical discussions about some of the guidelines and how practical is it in specific clinical scenarios. Okay, back to our faculty as well as the audience. Please feel free to participate as we walk through the cases. So this is a patient with high-risk non-muscle invasive bladder cancer with both multifocal high-grade T1 with carcinoma in situ. They completed a full induction course of BCG therapy with limited toxicities. The first follow-up cystoscopy at 3 months was normal, and urine cytology was reported as atypical urothelial cells. They completed 1 course of full-dose maintenance BCG as per the SWOG schedule with limited local toxicity. Second follow-up cystoscopy at 6 months was normal, and on this occasion, urine cytology is suspicious for high-grade urothelial cancer. I think we're all aware, I'm just going to emphasize the Paris consensus classification for cytology was an effort in 2016 to really try to help improve intra-observer variability, trying to standardize some definitions of the categories. So, there's not a lot of qualification terms on reporting of cytology into 5 morphologic criteria to try to create more of a consensus. This has been evaluated in multiple publications since the initial implementation of version 1. And throughout the world, I think there's been high adoption of the Paris consensus classification, and it's demonstrated several important topics that the goals of the committee of what they wanted to accomplish, many of the goals were sufficed. And one of them was this conundrum of this atypia, atypical urothelial. It's now referred to as atypical urothelial cells. Again, there's a lot of terminologies used in the past outside of Paris consensus classification about cytologies that aren't conclusively positive or negative. A lot of terminology has been used. So I'm going to kind of focus on the Paris consensus classification. AUA statement is up there about how they feel about a cytology that's atypical. What would you do with that? And so I'm going to turn to Dr. Witches first. Dr. Witches, first of all, when you get an atypical cytology and a normal cystoscopy, is there any value in repeating it, even just repeating the cytology?
Oh, come on, I don't get atypical cytologies. We really use the Paris system, and my cytologist, she said you have to know what your cytologist does, and they know what we do. So they are fortunately relatively black and white, so I get a 4 and a 5, and that for me would be abnormal. Second thing, if I would be in doubt, I would, which I do in my country, I would use a marker to see, to add to the proof that it might be really urothelial cell carcinoma.
What marker would you use?
We use the APCheck marker, which has a very high negative predictive value. So if that would be negative, I would do nothing. If that's positive, I would go in and look for prosthetic urethra, upper urinary tract, or whatever.
So a urinary marker that looks at methylation profiles is your choice. Dr. Kant, what do you know, so the Paris criteria have the category atypical urothelial cells. It's been demonstrated, it's reported about 5 to 15% of the time now that the criteria has been implemented in thousands of patients worldwide. That category is narrowed to 5 to 15%. What do you do with an atypical cytology?
I do exactly what's recommended in the guidelines. So if it's positive, it's positive. If it's negative, it's negative. If it's atypical, which is a very small percentage, but our pathologists truly will report atypical, we actually have a built-in reflex. So if it's atypical, the pathologists themselves will run the Eurovision FISH assay and then report the final results to us. So we don't have to do anything different. They just do it.
So you use Eurovision
It's a
FISH.
reflex. It's a reflex
A reflex test. I'm just going to pull the audience to raise your hand, please. Anyone use a urinary biomarker when you get an specifically atypical urothelial cytology? Anyone using a urinary biomarker? Anyone? No. Okay. And certainly, you know, it's based on AUA. It's just expert opinion to consider it. And there are 2 that are specifically specified in AUA guidelines. So personally, in this situation, at the 3-month, I did not pursue that atypical urothelial cell. But now at 6 months, it's suspicious. So I think we're all in agreement that that needs to be pursued with further evaluation. Cystoscopy remains normal. I don't think there's a role for a biomarker here. Approach in the operating room, Dr. Kamat, to evaluate an abnormal cytology.
Yeah, this is where Dr. Witches' diagram and all of that is very important, right? Because here you're looking for something that you can't see. So use blue light, make sure you evaluate the upper tracts, and make sure you evaluate the prostatic urethra.
Yep.
Okay, seems like we're all good with that. So these are the details of the patient. Everything's pretty normal, can't find anything. What do you guys think about evaluating the upper tract at the surgery? What's your approach? Normal lower tract. You don't see anything by blue light or white light. I won't get into random bladder biopsy, yes or no. I think there'll be variability of approach. If you don't see anything with enhanced cystoscopy, you biopsy the prostatic urothelium. What's your approach to the upper tract other than urography at the time of the surgery? Anyone routinely do ureteroscopy, collect cytologies from the upper tract? What's your current view?
I would do the last. So we put in then urethral catheters. Don't do that at the same time as you do your bladder validation, because if there is CS in the bladder, you will also rinse that up into the pelvis. So we will put in a urethral catheter. The next day, 2. The next day, we will sample that urine and see whether there's a cytology that's abnormal, yes or no.
Dr. I think you would have a hard time in the United States doing that. But I like that approach, but on the second day, I think you'd have a hard time keeping the patient with catheters and going up and getting it the second day.
Yeah,
so what's your approach here?
Everything in the U.S. is outpatient, right? I prefer still today CT urography, right? I think that's still a good way to know before you go to the OR what you're looking in. If the CT urography is pristine, I don't do ureteroscopies, but I will sample the upper tracts. And I just make it a point for the reasons Dr. Witcher said is make sure the bladder is flushed out before you do anything in the upper tracts, because yes, we can't keep the patient overnight just to do washings. If the bladder biopsy is negative and the upper tract is positive, I believe the upper tract. If the bladder biopsy comes back positive, a CIS, I'm less likely to believe the upper tract and think maybe it's a contamination.
I suspect there's quite a variation of approach. When you have a normal lower tract, you do your relevant biopsies, whatever you feel is indicated. I'll have a raise of hands here. Upper tract evaluation in that context, anyone do routine ureteroscopy of the upper tract to really drive sensitivity of tumor detection? I see a lot of no's. How about barbotage of the upper tracts? Everyone still doing that? I see the majority of hands go up with that. Okay, even with a normal CT urogram, would everyone do a barbotage? I see several hands going up with that too. Okay, so this patient had barbotage and came back as suspicious for urothelial cancer cells. So I guess it's pretty straightforward. Everyone agreement now ureteroscopy is indicated. You got a cytology that's positive from upper tract. Urography was normal. Schedule the patient back in the operating room again now for ureteroscopy. Anyone doing office ureteroscopy? No?
I am.
Are you? I'm doing a few here and there, select patients who I don't think will cause a lot of fuss. No, not a lot. Okay. All right. Let's move into a different case. Let's leave the high-grade case alone. Let's move into an intermediate risk patient.
Do you have a resolution on that patient, or that's the next
Found
step?
nothing.
Okay.
So I think that's I think that's a common clinical scenario, chasing these upper tract cytology, not like lower tract. That happens not uncommonly either. We're chasing the abnormal biomarker. In this case, cytology can't find anything, including biopsy. This case, same thing. Can't find anything on ureteroscopy, and follow-up CT urography can't find anything.
I was going to ask, like, what's your follow-up program for these patients, where they keep coming back with suspicious and atypical cells? How do you do further? Like, do you plan for another ureteroscopy on the same side, like in 6 months, 3 months? How do you proceed there?
Yeah, I think that's a very practical question. I think personally, I don't always routinely schedule another follow-up ureteroscopy in short order if I'm quite confident in the quality of my upper tract ureteroscopy. But certainly CT urography at that point, I think, becomes highly relevant, and to do that fairly often. And you might risk stratify that based on what the patient's bladder cancer history was like, because that's certainly a risk factor for potentially developing upper tract cancer. So you might change your schedule of how often you will do it, but I certainly will follow that up in 3 months with a CT urography, and likely another one by the year's end, and I would continue to pursue cytologies, and based on that might drive my decision to do another ureteroscopy at some point.
And quick question about office ureteroscopy. Do you use nitrous or?
Yeah,
like
now we
sedation?
do have nitrous available now, so I'm much more keen to start doing them. But even pre-nitrous, with sedation, we're doing the occasional ureteroscopy, but certainly with nitrous, that's helped considerably.
Yeah, we don't use nitrous. So in patients who have large UOs, patent, where it's easy, and we give a little sedation, this Versed, Ativan actually, even oral. Anybody that needs more than that, we take to the operating room. It's easy. But to make a point about the question you raised, which is very practical, I get referred to a lot of patients who have had persistent positive cytology from the upper tract for years, persistent positive markers for years, and then they come to see me, right? So if the cytology is negative and a marker is positive multiple times, throw out the marker. Right, trust your cytology. If the person has had persistent good evaluation, there's nothing going on. But there are enough patients, at least, that have cytology that's positive, and then get CIS in the upper tract. That, again, I'm not saying this is based on large series or anything, but I have treated with BCG for someone that has persistent high-grade positive cytology, and then the cytology converts. Right?
Of the upper tract.
Upper tract, yeah. And then
how do you do that?
I was
Nephrostomy too?
I was going to say that.
BCG?
Yeah, that's the next question. How do you do that? You just leave a stent, or you do a nephrostomy?
So no, leave it up to the patient. So we do it both ways, and I used to think the patient would hate a nephrostomy tube,
Right.
which is why I would do a retrograde, just it's in the office. You put a stent up and put the BCG by gravity. But when you offer it to patients, half the patients actually say, well, no, just put the tube into my back, leave it for 6 weeks, and then take it out later. So I leave it up to the patient.
Thanks, great.
Question?
Yes, if you do arthroscopy and you find a tumor, then you make a biopsy, and so you're manipulating the tumor. Then I heard someone is putting some gemcitabine or even mitomycin in the bladder after the manipulation of the upper tract tumor. What are your thoughts on that?
I'll make a brief comment and I'll turn it over. So I think, we don't have the purity of the evidence that in that situation, whether it's a low-grade or a high-grade tumor that comes back on biopsy, that giving that single dose post-ureteroscopy, whether it's biopsy and treatment, has a benefit. But certainly in nephroureterectomy, in guidelines, it's a category 2 evidence that, it's endorsed, and there are trials that giving that single dose post-nephroureterectomy reduces bladder cancer recurrence rate. So I think it's a very similar phenomenon we're talking about, but why we do it. But I don't routinely do it. Or I don't. I shouldn't even say, I don't do that, but it's a very good thought. And if anyone on the panel give a dose of perioperative chemo post-upper tract treatment or biopsy of a tumor?
Yeah, we do. Again, 1 dose of mitomycin C,
You do.
gravity. We don't use a nephrostomy tube. I would be a little bit afraid if there's a tumor that you would puncture the tumor. So we put in a urethral catheter. Double J's also don't work because then you have to put the patients upside down to make sure that it goes to the renal pelvis, which doesn't work. So we leave in a urethral catheter for 24 hours, give the installation, and take it out.
Okay.
Dr. Kmet, do you give a dose post-upper tract treatment of a tumor to the bladder to reduce a bladder recurrence from the migration effect?
No, I don't. I mean, again, it makes sense, but we don't do it. But if there's multiple tumors and you manipulate it, I mean, it makes perfect sense what you're saying. We just don't do it as a matter of routine. Yeah, and I agree with the point that you made because we still see too many people putting double J stents in and hoping that what's in the bladder goes up to the upper tract. Double J stents don't work.
Yeah. Thanks.
Appreciate the question. Okay, we're going to move to another case. I'm just going to check our time. I want Dr. Kmet up on the stage at 9 o'clock. So we're going to walk through this case over the next 10 minutes or so. So 58-year-old healthy female, a recent complete visual TURBT, 3 papillary tumors. And you see the location there, about 2 centimeters in size, so 3 tumors. And she received a perioperative dose of gemcitabine. Pathology, low-grade TA, urothelial cancer, no muscle present in the specimen. Concern either of you? No muscle on the pathology? Dr. Witches, Dr. Kmet, low-grade TA?
Well, it says muscle present, but even if it wasn't present,
what I wanted to ask is if muscle wasn't present, no concern?
whatever.
No repeat TUR? Okay.
No.
Okay, because it's low-grade. Okay, fine. Here's what I'm going to ask you. You put up, you gave a couple of options based on guidelines, in this risk category to give an induction chemotherapy or induction BCG. Let's just start with the induction discussion. How do you choose which agent? How do you decide chemo, BCG for this population?
I guess in this patients, I would probably use chemotherapy. The schedule I use already for 30 years is 4 times weekly and then 5 times monthly. Why? I don't know. I've been trained like that, but I'd give a course of chemotherapy.
Dr. Kmet, chemotherapy, BCG. Guidelines say you have 2 options here.
Yeah, if you look at the data, BCG is superior to chemotherapy in this patient. But if you look at the real world, we don't have enough BCG, so we use chemotherapy.
So BCG shortage, I'm hearing, is kind of impacting our decision about what to do. We did have a little verbiage about recurrence rates. If you're going to give maintenance with BCG, you have a better opportunity to reduce recurrence. What about maintenance therapy with chemotherapy? What's your view about the strength of the evidence for that? Dr. Richard, you advocated for chemotherapy in this patient, and that's what I did too, which I'll share on the next slide. Do you give maintenance? And if so, what schedule do you do with chemotherapy?
Well, again, these are really trials from the 90s and the beginning of the century done by the EORTC, and I looked at that with Richard Sylvester, all the chemotherapy trials that we did. And you have to start with a quite intensive schedule, like I do 4 times weekly, but could also do 6 times. And then around 6 to 12 months of maintenance, and usually that's 1 times monthly. And more doesn't make sense, less is a little bit worse. but that's more or less what you would do between total treatment between 6 and 12 months.
So monthly treatment for 6 to 12 months.
I give 4 times weekly, 5 times monthly. So I treat for half a year.
Dr. Grant, do you give chemo, a maintenance chemo?
Yeah, no, absolutely. And again, like Fred said, it's evolved over the last 25-ish years, right? What's right, what's wrong, et cetera. But if you look at the preponderance of data, that induction works well, but then you get that added boost. Because if you look at all the curves, they drop off, right? So that so I do monthly maintenance, and depending on the risk of the patient, this patient I wouldn't worry too much about, but if you move to, say, BCG-unresponsive and I'm using chemo, there I'll do monthly maintenance for up to 18 months. Because if you can get a patient to 18 months, they almost, there's never 100%, but very rarely recur after that. But before that, they do. Now, in this patient, there's less likelihood that that would happen because it's, I know we're calling this intermediate risk bladder cancer, but in the US, again, sometimes there's access issues, right? I've had patients whose tumors are 2 centimeters in size and they have 3 tumors because they've just not gone to the doctor. They probably had this tumor in for a long, long time, it's grown. So do you really need to put this patient through a whole year of treatment? So sometimes we use the 3-month cystoscopy to decide that, but I would give an induction and in my mind think that I do need maintenance.
How long?
A year.
A year. Okay.
So again, we have 2 options here. The guidelines recommend you have an opportunity for chemo or BCG. We kind of talked about reasons that might impact that decision. I'm just going to poll the audience. How many give chemotherapy in this situation as opposed to BCG, an induction course of chemo, whether that's mitomycin, gemcitabine? So I see, and BCG? So about 50-50 in the room. And those who give chemotherapy, raise your hand. Do you give maintenance chemotherapy on some schedule? So pretty much the same number that if you're doing induction chemo, you do go on to give maintenance. Okay. So the patient did get a 6 weeks course of intravesical mitomycin C, monthly maintenance mitomycin for 9 months. Cystoscopy and cytology were normal, except at 1 year of follow-up, 2 papillary tumors were demonstrated by office cystoscopy. They certainly looked low grade, and the cytology came back as negative. We're just going to put up some general questions here at this point about some concepts I think that we should all be talking about. To the panel first, would either of you suggest active surveillance? No treatment. Past history, low-grade TA tumor, cytology is negative, they look low-grade to you, small tumors, what about surveillance?
Yeah, no, I mean, again, that's a subject matter of another full 2-hour course, right? Should we do active surveillance or not? The short answer is in patients that have certain criteria, and you can set that at your hospital, you can set that at your system-wide level. Active surveillance is very reasonable for patients if that's what they want to do, and you're sure it's low grade, and you're sure there's no, high-grade tumor hiding in there. So would I discuss it with the patient? This patient, absolutely. Except this patient's been on maintenance treatment, right? And the tumor still recurred. So I don't think this will just stay stable. It looks like this is something that's going to get worse, which is why option 3 I wouldn't choose either, because this patient's been on chemoablation and not responded. So I wouldn't just switch to another drug and chemoablated. This patient, I would be more likely to do office cauterization or take to the OR.
Okay, I like that.
Exactly the same. You have a recurrence, 2 recurrences 3 months after your chemotherapy. So in this case, I wouldn't do active surveillance, which I do a lot. And I would also do office fulguration, absolutely. Yeah.
I certainly think, I certainly agree with, office fulguration is very easy. Patients, really are comfortable with that approach. In this specific patient, I think that's a very feasible option, but I'm not going to dissuade the fact that active surveillance, I think, is reasonable in this situation, with a counsel discussion. I think certainly it's appropriate. The danger and the risk to the patient is not high, and you will follow them up on some type of a follow-up schedule to monitor for tumor growth, symptoms, increase in tumor number. Anyone in the audience using active surveillance for their low-grade patients? Very few, but I did see, I think, 3 hands that I counted.
Don't be ashamed to put up your hand.
My hand's up. Yeah. So yeah, I have several patients on active surveillance in my practice with various features. Okay. Anyone want to comment on anything I put up there before we have Dr. Kamat come up and give his talk? Many doing office fulguration over TUR, preference of office fulguration, feasibility in your practices to be able to do that? Please.
Yeah, I mean, I've done a couple of office fulgurations. It's kind of sort of a routine now, especially like you said, low-grade pathology. My question was about switching between treatments. You know, when you have had maintenance treatment and they recur, you become nervous about like whether you want to keep going the same treatment or you want to switch to another agent. Sometimes patients have a completely variable response. That they would. I've got one patient who like completely refused to go on gemdosi because she previously received gemcitabine and she had a very horrible response to that. So, how do you decide that switching between agents? Should you keep doing the same? For this patient, would you go back to mitomycin, or would you switch to maybe gemcitabine? How do you make that call?
Do you guys want to comment? I think it's
I think you skipped a slide with the International Bladder Cancer Group
want me to go back?
recommendations. No, you don't have to, but essentially
Okay.
in that, it clearly states if a patient is not responding to chemo, try BCG, right? It states that. If you have BCG. If you don't have BCG, then your hand is forced and you have to switch to another chemo, but
Yeah, that's the biggest problem because the limited supply, we are going, half dose, 1/3, whatever.
right. Then you try
So-
another cytotoxic, right?
You
Yeah.
do another,
Yeah.
okay.
Yeah,
Just
maybe,
keep
maybe,
switching.
I think that was the comment I was gonna bring up. I think the scenario here is what if a patient's had prior chemo and they failed it? They've had BCG, they failed it. Now what? Do you look for a chemo agent with a different mechanism of action? And if so, do we know what the efficacy of that is? I have many of these patients in my practices, we all do.
We've actually
it's
published on that.
complicated.
We published on that, and Mike O'Donnell has too, that in those patients that don't seem to respond to single agent chemo, multiple ones, and BCG, the gemdosi response is much better than we thought. So we use gemdosi, and we've had very good results with it. But that's also the kind of patient where the trials that are currently starting to open up, FGFR-directed therapies, those kind of things would really, I think, make a big difference.
Thanks.
We use, by the way, chemohyperthermia, which does very well, but you have to have the equipment.
Yeah, we don't have it in the U.S.
Yeah.
Yeah, if we had it, that would be another good choice.
Send them to Nijmegen.
Okay, Dr. Kamat's gonna come up and talk about a role for radical cystectomy in these high-risk patients.
Thanks, Kamal. And I have to say, it's really wonderful to see the level of interaction that this audience has had. So please keep that up and ask questions. I'm going to try and keep it short so we can go back to your case. So don't worry about timing. My disclosures. The question really of this topic is, when should we move to a radical cystectomy in patients with non-muscle invasive bladder cancer? I think the easiest way to answer that question in your mind is when not removing the bladder would present a loss of opportunity to cure your patient, right? Because the one thing that we always think about is, yes, I don't want my patient to lose his or her bladder, and we try everything we can, even in the BCG-unresponsive space, but at some point you miss that window, right? So the way to flip that question around and say, what are the indications for a relatively early radical cystectomy or radical treatment if your center does trimodal therapy, but radical treatment in patients with non-muscle invasive bladder cancer? So when do we consider radical cystectomy in non-muscle invasive bladder cancer? These are sort of the 4 boxes how I think of how to counsel my patient. So the first one is if the patient has T1 high-grade disease, CIS along with it, T1B high-grade disease, or involvement of the prostatic urethra. And this is what's in the guidelines. And if you look at these very high-risk patients, what the AUA says, what the EAU says, what the International Bladder Cancer Group says. And I've showed these slides before, but I think it's really important to emphasize. We think about T1 disease as superficial bladder cancer or non-invasive bladder cancer, but it's not. It's non-muscle invasive bladder cancer, right? And for the surgeons in the room, we know the bladder is not this thick. It's this thin. So the difference between T1, especially if it's T1B, and T2 is sometimes a matter of cell layers. And that's why if you actually look at the survival of a patient with T1 high-grade bladder cancer and try to extrapolate it, and Jed Ferguson, who was a fellow with us, did that and published it, and Nima Nawai as well, you can see that the survival is the same as a patient with Gleason 10, 12 out of 12 course positive, T3B disease, PSA 75. And that's not a patient you would think of as having non-significant prostate cancer. So why do we sometimes think of T1 high grade as not being relevant, right? So T1 high grade bladder cancer, yes, try to save the bladder, but my first meeting with the patient, I tell the patient,
At some point, you might need a radical cystectomy. We're going to try to avoid the radical cystectomy, but every time you have a negative cystoscopy, that's a victory, right? It's not, don't take it for granted. Because the other thing sometimes happens is patients think if you tell them, okay, let's just try BCG, and then the tumor recurs, they're like, but you never told me that I might need to have my bladder taken out. So you have to set that expectation early on with your patient. And clearly, there's sufficient evidence to show back in 2007, Denzinger published this. More recently, Pat Hensley published it with our MD Anderson series. If you do a radical cystectomy early for patients with T1 high-grade disease, they do oncologically better. Again, most patients don't want a radical cystectomy, so I'm not saying we should rush to it, but we need to keep that as it's a negative prognostic factor for our patients when they have T1 high-grade disease. The second category really is that lymphovascular invasion. And Fred alluded to that in his talk about, we need to consider all of these and how come it's not in the guidelines. There's plenty of evidence, but a very good review was done, a systematic review that was led by Shahrukh Shariat. And you can see there that LVI not only increased recurrence rates, increased progression rates, and increased, deaths from bladder cancer. So if you have lymphovascular invasion in your TURBT specimen, that means the tumor's already gotten into the lymphovascular system and it's heading towards T2, but also node-positive disease, right? So those are patients in whom, if you really think it's T1B LVI, even for non-invasive disease, you can consider neoadjuvant chemotherapy, right? Because it's that much of a serious issue. So stage those patients very appropriately, do whatever staging you use routinely, make sure they don't have lymph node positive disease before you rush straight to a radical cystectomy. And again, data has shown multiple times, old data, new data, LVI really makes a difference. The third sort of broad category is the histologic subtypes, or the variant histologies, such as micropapillary disease. And this is in the updated AUA guidelines in 2024. It's in the EAU guidelines. It's pretty much everywhere. Because patients with variant histology have not only a high rate of being upstage, but also poor outcomes with intravesical therapy, strongly recommend radical cystectomy to your patient. Again, your patient may not want a radical cystectomy. It's up to us to tell the patient the data and actually guide them in the right direction. And if a bladder sparing approach is being considered, this is one patient, even if it's TA disease, I would go back and re-resect because I clearly want to make sure there's no T1 variant histology. There's nothing really that's going to hurt or kill our patients. And by hurting and killing, this is what happens. So this is an old series from MD Anderson that we published back in 2006. But with micropapillary disease, for example, if you put your patient on a trial of BCG, that's okay. But remember, the recurrences and the metastases occur early. Whereas with high-grade non-variant histology, usually the recurrences will occur early, but not the metastases. So this thing that sometimes we see in papers where let's try some BCG, and if it doesn't work, we'll take you to radical cystectomy. You can miss that window. So routine, good quality surveillance, imaging more often than you would normally do for non-invasive disease is really required if you're taking a patient with variant histologic subtype down that journey of bladder conservation. And, I didn't know I had that transition in my slide. And this is an effort that Fred led, essentially, where the EAU ESMO consensus for micropapillary, 86% of the panel agreed early radical cystectomy. The other 14% disagreed, probably because, again, we want to give our patients an option, but it's not necessarily the right option. So just to summarize that, this is a review that was published by Dan Willis and Seema Porton. And you can see here that the way to think about non-invasive disease, if it's the histologic subtypes are sarcomatoid, plasmacytoid, or micropapillary, consider early radical cystectomy. If it's small cell, which is neuroendocrine differentiation, you always have to consider any small cell in the bladder just being a local manifestation of a systemic disease. You should use chemotherapy first, and then you could use whatever you want in the bladder, including observation, right? Or consider radical cystectomy. And if it's pure squamous adeno, we all know you need radical cystectomy for that patient. The last group is something, again, that Fred spent a little time on, so I won't spend too much time on this, other than to emphasize the definition, because at this meeting and a lot of publications coming out, we're all hearing about BCG-unresponsive disease, right? Keep in mind, though, that if BCG is used appropriately, and this is a series from our place that Justin Madeley published, it works really well. A lot of old data suggests that BCG progression rate is 30%, recurrence rate is 70%. That's just not true. we urologists have gotten better with better scopes, better resection, our pathologists have gotten better. And if you look at contemporary series with appropriate BCG therapy, progression rates are in the single digits all the way up to 5 years, right? And recurrence rates at 3 years, 24%. So 76% are recurrence-free at 3 years and 74% at 5 years. Totally different from what a lot of these drug company trials have used to actually design their studies, which is why many studies that are looking at BCG and BCG plus X did not read out in 2021. They haven't read out in 2022, not in 2023, not in 2024, because the events in the control arm are a lot less than what the trials were powered for. So keep in mind, BCG works really well, but it also does not work for some patients, right? And we use BCG's response to classify patients as BCG naive, BCG exposed, and BCG unresponsive. And that BCG unresponsive definition was proposed to the FDA by the GU-ASCO group and the IBCG, and it was adopted. But what is that essentially? So a patient has to have adequate BCG, which is 6 weeks installation of induction, and at least 1 attempt of maintenance. And if that occurs, and then the patient falls in that category with T1 disease at the first look, or CIS that's recurring within 6 months, or papillary disease recurring within 12 months, or sorry, CIS within 12 and papillary within 6, then that's considered BCG unresponsive disease. There's tons of options for patients with BCG unresponsive disease. I'm not going to spend a time going through all of that. Dr. Witches went through those in his talk, and there's plenty of stuff going on at the AUA. But I do want to show this one slide to you all. This is a nice review that was done and published in JAMA Oncology by Dr. Wong. And if you look at the line, the historic lines, actually I do have a mouse here, right? Yeah, so if you look at this historic line here, that's the historic evidence with valrubicin, right? So valrubicin was the only drug approved for BCG unresponsive disease in the US for many, many years, and it really had a dismal response rate early on, and especially at 12 months it was 4%. So back when we made recommendations as part of the International Bladder Cancer Group, we, again, expert opinion, arbitrarily set this line here at 50% at 3 months and 30% at 12 months, and said, if you can sort of beat this benchmark, it'll be a boon for our patients. So if you look at the different agents that are currently available in the US, Gemdosi is available. It's off-label. We use it very often. It's actually standard of care for patients who are not eligible for clinical trial. Gemcitabine and docetaxel beats this arbitrary benchmark clearly by a lot, right? If you look at pembrolizumab, it kind of straddles this benchmark, and here it drops below the benchmark, which is why a lot of people don't use it, also because of the toxicity. If you look at nadofaragene, which is the gene therapy, again, straddles the benchmark at the first evaluation. Here too, it straddles the benchmark, so it's a reasonable option to offer to your patients. And N803 was just approved like 4 days ago, right? Anktiva, which is its trade name, was approved 4 days ago. Again, straddles it early, but here it beats it. This is an immunotherapy. So with an immunotherapy-based agent, you would expect the tail to kind of be better, which is why I think this looks better than later on than the benchmark that we set early. So I just wanted to put this up there as an interesting exercise, and then also put this next slide up. So if you look at this here, this is data that was presented here at the AUA, and this is drug X, right? This drug X literally at 3 months in small numbers is presented to you, and they show you at 3 months it's got a 75% response rate, and the duration of response is 86 months, and would you approve this drug? And everyone would be excited. But what was this drug? It was more BCG, right? So in some patients that did not get or qualify for a clinical trial, and there was nothing else available, and we said, well, let's try some more BCG, the response to BCG, even in this group of patients, is pretty good. I'm not saying we should use BCG for everybody. That's not the message of what I'm saying. But we're saying we should move to randomized trials, because otherwise it's really hard to figure out what the effect of a drug is if you're just doing single-arm studies. And lastly, again, bladder cancer is a multidisciplinary approach. This is May, it's Bladder Cancer Awareness Month. Just to plea to everybody, think of this as a multidisciplinary cancer, and engage your medical oncologist, engage your pathologist, engage your radiation oncologist. And with that, I thank you for your attention.
Ashish, if you can go 2 slides back, then you almost would think that all the current trials will fail.
Why would that be?
Because they compare to BCG, which actually is a very good second or third line therapy.
No, the current trials don't compare to BCG.
But
right?
some do.
In BCG-unresponsive space, none of the trials compare to BCG. And that's what I'm saying, we should compare to BCG.
Okay, yeah.
Yeah, none of the current trials compare to BCG. The FDA has allowed them to just do single-arm studies. I am saying that now that we have so many drugs approved, if you want to compare to anything, compare to Gemdosi, compare to Pembro, compare to more BCG, but we need to sort of move away from single-arm studies.
Great. Okay, I have one more case. Great, thank you. All right, a 78-year-old gentleman, history of coronary artery disease, atrial fibrillation, hypertension, hyperlipidemia, moderate functional capacity. He's bothered by LUTs and he's on finasteride. Newly diagnosed with high-grade TA urothelial cancer of the bladder. 4 tumors, largest one was 4 centimeters in size, had a complete visual TURBT, muscle was present. He completed a full course of induction BCG therapy. He was bothered by local symptoms, was fatigued for 2-3 days. He was given a fluoroquinolone a few hours post-BCG treatment. Cystoscopy cytology at both 3 and 6 months were normal. He did go on to get maintenance A BCG as well as maintenance B BCG. So he got 2 more courses of maintenance BCG at the 3-month and 6-month follow-up cystoscopies according to the SWOG schedule. I'm going to go back to a slide that Dr. Witch has put up about the real perceived benefit. I mean, we're all concerned about the stewardship of BCG, but we're also concerned about our high-risk patients. Dr. Kamat presented that, you know, we have some modern results of truly what are the recurrence and progression rates. They're not as striking as we thought historically. But what is the real benefit, Dr. Kamat, in the 2nd and the 3rd year of maintenance? What about stopping after 1 year? 78-year-old gentleman having a bit of a hard time coming back and forth to the office, bothered by local symptoms. He's fatigued 2-3 days after the therapy. It's bothering his quality of life. What do you think about stopping at 1 year?
Well, it's obviously shared decision, but I would certainly discuss that with the patient. Absolutely. Yep. You only risk a little bit more the chance of recurrence, but not progression or other nasty endpoints. So I would discuss it with him to stop after 1 year.
I want to emphasize that. Dr. Kamat, what do you think about that 2nd and 3rd year, that the progression benefit from the 1st year of maintenance has been achieved and that the 2nd and 3rd year don't give us progression benefit?
Yeah, no, I agree completely. I mean, I do want to emphasize that if you look at all the data with BCG, though, as with any immunotherapy, duration is important, right? So if you can reduce the dose and get the patient onto longer duration, it's better than trying to stick with that high dose and beat the patient into submission. So you can reduce the dose, you can use multiple things, but if the patient just has access issues, you know, a lot of our patients have to have their grandson or daughter take time off from work and come. I mean, for those reasons, absolutely. After a year, that incremental benefit is small. It's there, but it's small. And in this patient, it makes sense to do a shared decision making, like Fred said, and hold off on more BCG.
So at the 12-month cystoscopy, the urine cytology is suspicious for urothelial cancer. There are areas of erythema noted on cystoscopy in the office. In the operating room, those areas are biopsied. There's presence of multifocal carcinoma in situ, no papillary disease. He has normal upper tract evaluation. The prostatic urothelium was not biopsied. Dr. Kamat, what do you think about that? Would you routinely biopsy that? How much is that going to impact the decision of this patient moving forward? I'll just answer the question. He's BCG unresponsive based on the definition that Dr. Kamat put up. So he's a BCG unresponsive patient, has received an induction course, 2 maintenance courses. Last course of maintenance was 6 months ago. He has carcinoma in situ. Prostate wasn't biopsied. What do you think of that?
Yeah, it makes a big difference, right? Because the prostatic urea is a sanctuary site. It's a site. You didn't use blue light, or blue light was used. It was used here, yeah. I mean, blue light doesn't help with the prostatic urethra. I was just asking the question to know. even though you use blue light and you did directed bladder biopsies that were positive as CIS, there's a good percentage of patients, it can be as high as 40 in some series, that have prostatic urethra CIS. And then if you were to counsel him for a clinical trial, they would require it anyways, right? So I do prostatic urethra biopsies routinely.
Dr. Rich, do you routinely do, in this situation, would you routinely do it?
Absolutely. Yeah.
Okay. Would that influence your decision before I move to the next slide, radical cystectomy versus more conservative bladder-sparing options if you knew they have CIS of the prostate? How does that influence your decision?
Well, of course, he's 78 and not probably in a very good condition, but still, you know, if the prostatic urethral biopsies are positive for CIS, I would really consider cystectomy if he's fit enough to do that and accepts it.
Dr. Grant,
or a trial.
what do we know about the agents you were putting up, N803, pembrolizumab with CIS of the prostate? What's the safety of those agents versus radical cystectomy?
Yeah, that's another plea to industry and investigators, right? Because those patients are excluded from all the clinical trials.
Yeah.
And that's a large chunk of our population that's BCG-unresponsive. They have some variant, 10%, they have prostatic urethra involvement, and they're excluded from all these trials. So obviously, don't blame the companies, they want to make the trials look good, but we just have no knowledge in the real world as to whether these drugs work in prostatic urethral CIS.
So the message we're getting from the panel is prostatic urothelial biopsy is important if you're falling into the BCG unresponsive space, even if you're not in the unresponsive space. I think, you know, always have to be cautious about that, you know, what's the value of that knowledge. I'm going to just put this up. It's going to cover a large part of, a portion of Dr. Kamat's talk and Dr. Witch's talk. So I am going to kind of list the agents here one by one. So we now have 4 FDA approved agents. Valrubicin is a little historical. The other 3 are very new, and one of them has only been in existence for 2 weeks. So what agent do you choose? Dr. Kamat, how do you make this decision? It's complicated. A lot of approved agents, and I put gemdosi there. Dr. Kamat shared the data from the JAMA publication, JAMA Oncology publication. It seems to have efficacy despite it's not been studied in a clinical trial setting. How do you make this decision?
So again, just to clarify, assume this patient did have prostatic urethral biopsies that are negative, right?
Negative,
Okay,
yeah.
so
Let's
we'll assume that
that.
this patient is truly BCG unresponsive only in the bladder. This is where you talk to the patient and make, you know, shared decision making. But my recommendation to this patient, so long as he can come to the office and his bladder capacity is amenable to it, would be consider a clinical trial. Assume there's no clinical trial available. You ask me to choose from these agents, I would go to gemcitabine and docetaxel.
I just want to follow back up on that. So we do have approved agents, but you would still prefer a clinical trial if it was available to you over an approved agent?
I would discuss it with the patient and let them know that these are the approved agents, these are their efficacy rates. And if you have time, I can tell you my thinking. Pembro is too toxic for this patient. He's 78, he's having a lot of issues, so systemic therapy with Pembro I wouldn't recommend. Nado has a 23% 1-year efficacy rate, and it's $60,000 a dose, right? So that's something I would discuss. 61,000. I would tell the patient we have it approved, but it's 23%, right, at 12 months. NAI is just approved, and it has really good results, but you have to give it with BCG. And this patient is having trouble with BCG, right? So if you have to give NAI with an agent that the drug patient is already having trouble with, I wouldn't want to force the patient to be miserable. Valrubicin, clearly, you know, it's a historic interest. It's approved, but it doesn't work at all. So what do we have? Gemdosi. What are the results at 2 years? 58%. I'd use it.
Pretty good results at 2 years. I like that thinking. I put the slide up purposely. You know, the point here is there are many factors here. That one is that Dr. Kamat is considering here when making a decision. You know, patients' comorbidities, bladder capacity, toxicities of previous intravesical therapies, patients' desire about trials and response rates. Dr. Witches, you have any other comments or thoughts you would share? I find it complicated here now. You know, should you move on from approved agents, really strongly consider a clinical trial? Gemdosi, where does it fit into this bucket when there are several approved agents?
Well, most isn't approved by the EMA, so that makes it a bit easy. But even if I would probably do the same as she does. And like I told you, in my hospital, that the patient would typically get hyperthermia. If his bladder is decent, otherwise I would go for gemdosi.
Gemdosi. I'm gonna poll the room. If raise your hand, please. Anyone use pembrolizumab in any patient to date in the BCG-unresponsive space? Anyone use pembro? So a couple of hands. How about Adstiladrin or nadofaragene? Anyone use that yet? It hasn't been around. It hasn't been available very long, but no use of it yet. Gemdosi in this setting. So yeah, tremendous adoption of gemdosi. So I saw pretty much every hand go up. And my last slide, I think we've already touched on about the, where do we fit in now? We have several approved agents. When do you consider a clinical trial? And I think we heard from the panel. So we have a couple of minutes to wrap up. Anyone have any, we have 5 minutes actually. So any other questions? Again, we really appreciate the engagement of the audience today. Any questions? Anyone want to come up? I'm going to emphasize, please fill out your course evaluations. It's very important to us. It's important to the AUA. We want to do better next year, so please tell us what we can do. Yeah, please.
Very interesting talks, thank you. Could you comment on your technique for the prostatic urethral biopsy? Is that a cold cup, single location, full urethral, TURP? Thank you.
Yeah, no, I mean, again, that's not quite as straightforward a response, so allow me a couple of minutes to go into detail. So if I'm just looking to detect prostatic urethral CIS, then the cold cup is sometimes sufficient, right? But that's not what I'm just looking to do, because a lot of patients that have prostatic urethral extension will have CIS that's going now into the ducts, and then maybe even the acini, and they may even have prostatic stromal involvement. So you need a loop diagnosis. And David Wood and Michelle Donat, I mean, they did randomized studies back in the day, small numbers, with transrectal biopsies, TUR biopsies, and they all showed that the TUR is the best. Usually done at 4 and 8 o'clock, because that's where the ducts tend to have the most depth and the viru, up to the viru. So that's where I do it with 2 loops, 2 resections. Not a full TUR. Unless this patient has a lot of CIS and I'm trying to remove a lot of CIS and then bathe the bladder with chemo, then I will come back and do a mini TURP to open up the bladder neck per se, but not at the first setting. The first diagnostic setting is 2 deep loop resections.
So those lateral montanal biopsies are, and I think it's in the EAU guidelines even, there's a description of
Yeah,
that.
we do exactly the same.
Next question, please.
Hi there. As a general urologist, not an oncologist, most of the patients I'm taking the OR, usually it's for, for a TUR, it's for BPH. And I have, I'm sure we all do, have these patients that have both a bladder tumor as well as BPH. I know in the literature it is safe to kind of do a TURP as well as a TURBT in most of these patients. I was wondering if you could comment a little bit on if that's true, or should we think about it differently as we risk stratify the bladder cancer part of it differently, as well as installation of perioperative chemotherapy in the setting of having also done a prostate resection as well, and how we should be thinking about the timing of that.
Yeah, good question.
Well, there have been 2 larger series combining TURP and TURT, TURBT. It doesn't apparently increase the risk of seeding in the prostate area. So apparently it's safe. I just wouldn't give a single post-op installation, because you probably have a large wound bed. But after that, you can just give systemic intravesical therapy.
Sure. With that, the inability to give chemotherapy afterwards, would that make you change your thought process about, well, we should stage those procedures so we can give 2 anesthesias, 2 OR times, but be able to give the perioperative chemotherapy and the bladder tumor resection part?
No, maybe if it would be a very large tumor where you suspect that it is maybe something invasive, I would maybe separate that. But if it's a smaller tumor, I would combine the treatments.
Yeah, I agree. If it's a smaller tumor, completely agree. But again, there have been instances where I've been referred patients that had a full TURP and a biopsy of a muscle invasive disease, and then sent to me for radical cystectomy. I'm like, the prostate's coming out. Why did you do the TURP?
Thank you.
Yeah, good question. Okay, again, appreciate everyone's attendance this morning. Enjoy the rest of the meeting. Safe travels home. Take care.